Hey everyone, today we've got another shoulder case study episode for you. This patient has really irritable shoulder pain. What do you think is going on? We'd love to take you through the assessment, the diagnosis, and all the clinical reasoning to help you in practice. So if you're ready to learn and test your skills, let's dive in. Hey everyone, Khalid here. Welcome back to Clinical Physio. Thank you so much for joining us for another case study, and this patient has shoulder pain. If you like this video, be sure to smash that like button to support our channel, and otherwise let's dive in with the subjective history. So first of all, we've got a 25-year-old male patient, and they are complaining of right shoulder pain at the distal clavicle. That's the key area that they're experiencing their symptoms at, the distal or lateral clavicle. Now, there hasn't been a specific injury or trauma that's caused all of their symptoms, but they've been noticing that this pain at their distal clavicle has been gradually getting worse over the course of the last 3 months. They report that they haven't got any focal neck pain, they haven't got any focal arm pain or radicular pain, no pins and needles or numbness. We do believe that this is all orchestrated at the shoulder. Now, this person is a very active 25-year-old with 2 main hobbies. Number 1 is the gym, and we can see that doing activities in the gym such as a bench press do irritate their symptoms. But the other main activity that this person likes to do is play rugby, and they've been playing rugby for many years, which means that naturally they've had bashes to the shoulder in the past. So currently they explain that when they're tackling a patient with that right shoulder, it seems to irritate the pain more. And also when they're throwing a pass to the left, so moving that shoulder across the body into adduction, also seems to irritate the right shoulder pain. Things that ease their symptoms: painkillers and rest from rugby, or if there's no match that week, his symptoms seem to be a bit easier. But we do know he has good general health, no significant past medical history. The key issue with this patient is his right shoulder pain. So next we dive into the objective examination. Now, there's no concerning features on observation. There's no specific redness, swelling or bruising, but we do feel that on the distal clavicle or the lateral clavicle, when we palpate it, it clearly is quite sore and tender for this individual. So we look at their active range of movement as well. We start with the cervical spine to just double check and clear this. We can see that our patient has no pain and no issue with movement of the cervical spine. We look at the shoulder range of movement, and actually he has really good movement of the shoulders bilaterally into flexion, extension, abduction, adduction, internal rotation, external rotation. However, it's clear that end of range flexion right at the end of the movement and end of range adduction both irritate the symptoms. So he's got full movement, but the movements are painful at end range for flexion and adduction. We go through resisted tests of the shoulder and find that there's no major concerns. He's got full strength and no pain on those tests. But one test that does seem to be irritable for him is a scarf test. That seems to bring on his symptoms in terms of his right shoulder pain. So that's our patient. Next is over to you. Can you work out what you think is going on? Take the opportunity to pause the video, write down your thoughts, and join us again in a second. Okay everyone, time's up. Let's go through the diagnosis. So for us, this patient was a relatively classical case of ACJ dysfunction. So we know that the clavicle joins onto the acromion to create the acromioclavicular joint, and right at the distal or lateral end of the clavicle is where it joins onto the ACJ. Now, this patient had quite a lot of indicators that pointed the ACJ out to us. First of all, the fact that his pain location and the pain on palpation was right over the ACJ, where that distal clavicle is. And you'll notice this is very much the case for patients with ACJ-specific pathology, is that they don't really report pain on the side of the shoulder, at the front or at the back. They report pain right at the ACJ, right at the acromioclavicular joint. And that can be reproduced on palpation as well. Really simple and focal sign for ACJ pathology. Remember that your patient might have other things going on like rotator cuff pain. However, when they have that focal pain at the ACJ, we imagine that the ACJ is likely to be implicated. Secondly, we've got some things in here which kind of point out why it may not have been other shoulder conditions. So why wasn't it something like a frozen shoulder? Well, we know that the patient had no stiffness at the joint. He's got full range of movement. So that moves us away from glenohumeral joint conditions, such as a frozen shoulder, as well as, of course, the age. But also, it kind of moved us out of the direction of a muscular issue like a rotator cuff tendinopathy based on the fact that he had full range of movement and no pain at all on those isometric strength tests. And the fact that he had 5 out of 5 strength with no pain kind of pushed the rotator cuff away from our level of thinking. However, there were other things that kind of pointed us towards the ACJ. Number one is the rugby situation. We do know that this is a feature for patients who play rugby, is that they have this repeated impact right into the shoulder, and having that repeated activity over a long period of time can cause irritation at the ACJ, and that was certainly the situation for him, where you get that compression of the ACJ, the acromioclavicular joint, that was clearly irritating his symptoms. And also his range of movement testing. So first of all, adduction compresses the ACJ, and this is in line with the scarf test. So the scarf test, where we passively bring the patient's arm into full horizontal adduction, which will compress that ACJ joint, and that was irritating his pain. So the adduction and the scarf test move well together there. But then if we think about the end of range flexion, this is where the ACJ really has its role, because as we elevate the arm into higher ranges of movement, the scapula has to spin and rotate to give space for the arm bone to actually move into to generate that end of range flexion. So patients who have ACJ pathology don't normally report that the place where they have most of their pain is at 60 degrees. It tends to be in those higher degrees of flexion and abduction and elevation that aggravate their symptoms, because that's the position that's putting the joint under stress because of that need to rotate and flip in line with the scapula. So for all those reasons, we thought that the ACJ was the problematical area here.
So next, let's talk a little bit about rehab. What did we actually do for this patient? First of all, it's absolutely worth saying that treating ACJ dysfunction is difficult, particularly for individuals who are then going to go back into the same impact activity that irritates their symptoms. For this individual, the rugby and the bench press and the other gym activities. So what are we actually trying to do when patients have ACJ dysfunction? Well, we can try and strengthen muscles, sure. And actually one key component might be trying to strengthen the upper traps in order to help with that scapular elevation movement. And for that, I might be placing my patients into positions of more flexion and trying to get them involved in elevation activities there in order to try and work those trapezius muscles. But otherwise, one of the key things that we try and do with the ACJ is proprioception and getting the shoulder used to having load being put through it. We see a similar thing with the patellofemoral joint. This is a joint whereby to rehab it, it's getting used to the joint surfaces of the patella and the femur with that movement of one surface over the other that we're trying to make more tolerable. We're trying to make the movement easier to cope with. Rather than focally strengthening the quadriceps muscles, improving the symptoms, it's more about getting the joint used to that tolerance of load. And that's the same with the ACJ. So it might be lots of weight-bearing activities, leaning in an all-four position to try and get the shoulder used to having load going through that joint. So you might be doing activities where the patient's weight-bearing through their hands and moving the legs, or weight-bearing through the right arm and moving the left arm. This could be done on a wall to start with to make it easier, and then done on the floor to make it more difficult. And those are some of the challenges that we have with these patients, is that because the symptoms are so irritable, we have to move quite slowly through the rehab program. However, it absolutely can be done. We just need to take our time and make sure that exercises are tolerable for the patient. So everyone, I really hope you enjoyed this video. If you have, please support us by smashing that like button. It's the #1 way that you can help our channel and show us your support. If you want more resources for us, make sure to check out our Instagram account at Clinical Physio. We've got loads of brilliant resources there for physiotherapists. And if you like learning by case studies, be sure to check out our membership platform, member.clinicalphysio.com. On membership, we have the Case Study Club, a brilliant resource where we go through lots of different clinical conditions with MSK experts to show us their clinical reasoning, how they came to the diagnosis with their patient, that will really help you if case studies is the way you like learning. So everyone, thank you so much for watching. My name is Khalid. See you soon here on Clinical Physio.